A very good morning to all of you. My name is Dr. Pang and I'm a preventive medicine specialist, and basically I'm involved in palliative care also, and that's why I'm here to talk about palliative care.
Okay, so Dr. Pang, can you please share with us what is palliative care?
Okay, I first explain the WHO or the World Health Organization description of palliative care. It is described as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening diseases. And this is done through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems like physical, psychosocial, and spiritual. So you have here a definition that is very different from medical or therapeutic care. When people go to see a doctor or go to seek treatment in a hospital, they are expecting to be healed, to be made well. But when you look at palliative care is improving the quality of life with patients facing life-threatening diseases, or rather diseases that are incurable. So here itself lies the main problem of why palliative care is kind of so taking a backward stage in Malaysia, because people don't understand. To them, I go and see a doctor, I go to hospital, I should be made well. But then palliative care is really like relieving the symptom from pain, shortness of breath, nausea, affirming life regarding dying as a normal process, or rather not hastening death nor postponing death, enhance quality of life. These kind of things people don't expect from hospital or from clinic or from healthcare. So they kind of a bit puzzled when you try to talk about death for that matter.
Alright, okay, Dr. Pang, so the next question is, do you mind to share with us what is the difference between palliative care and also hospice?
Okay, hospice really actually hospice care is a type and philosophy of care that focuses on the palliative care of terminally ill patient. Now, earlier on I said palliative care can be started early, even while doing chemotherapy, where they are taking care of the symptoms and all that. But hospice is defined as part of the palliative care of the terminal patient. In fact, in United States, because of healthcare insurance policies, hospice is defined as terminal care for the last 6 months of life. In other words, when a doctor certifies that this person needs hospice care, they are saying that this person only got about 6 months left. Then only the care is transferred from therapeutic hospital care to palliative care, but hospice setting. Alright, but in Malaysia there is no such division in terms of 6 months and all that. And by the way, it is really that definition becomes very disturbing, because when a patient says when they understand that they are asked to go to hospice, then they also understand that they are going to terminal stage. So when you tell people that hospice is only for terminal patient, or rather in Malaysia it's being misunderstood that way, that it's only for terminal patient. So a lot of cancer patients, when we say, oh, let's go to hospice or go to some NGO who's doing palliative care, they associate hospice and palliative care together, and they therefore say, but I'm not terminal, I don't want to go yet. Or when I'm quite sick already, then they said, oh, not yet, because to them it's those days, when your grandfather and your grandmother refused to go to hospital for treatment, because to them when they go to hospital they will die there and won't come out. So they will think that association of hospice with terminal care as the last stage of life makes it difficult for people to be open to palliative care in Malaysia. In fact, one of the problems is patients not being open to palliative care because they are not open to talking about death and talking about preparation for death and incurability of the disease and all these very negative things.
Okay, so Dr. Pang, why is it important for patient and family to accept that the disease is not curable?
Because if that acceptance is not done, then whenever the treatment fail, especially in cancer, then the family and the patient is going around hunting for another treatment, for another alternative. And then there are patients who are actually, till the day they die, are undergoing treatment, trying to find for a cure, when actually it is already at a stage where it is incurable. That is why palliative care cannot come in at very late stage, where patients are struggling with pain, they are struggling with a lot of things, they are still thinking that they can find cure. It should come in earlier, where palliative care can be actually together with the treatment for chemotherapy and radiation. Patients are given the perspective that this is a process, that there comes a time where we need to, we may stop therapeutic care and move to palliative care. But it's a problem here, you see. In Malaysia, the word death is taboo in a lot of cultures. In our multicultural society, people don't like to hear death. People don't want to discuss death. So how do you open the topic? Now, for many of us, we have some people who get trained in palliative care may become a bit enthusiastic and try to force the topic of death, like they don't want to know, but no, you must know, that kind of thing. But in reality, if you must understand that for some people, don't want to know about death is a form of their coping with death. By not wanting to know is the only way they know how to cope. So if you force open the topic in your enthusiasm to try and help in the palliative care, because part of palliative care is preparing for death, and yet the person does not have the support system to support them through this traumatic experience, you are then really doing a disservice. So you must understand the culture when you are trying to do palliative care.
Okay, Dr. Pang, so what are the type of patients that need palliative care?
Well, in Malaysia, most palliative care patients are cancer patients from cancer. But actually, in reality, because palliative care is life-threatening, long-term, incurable disease, so you can have patients from AIDS, HIV, alright? Then you have patients who have congestive heart failure, cardiac disease, lung disease, kidney failure, Parkinson, just about any disease that is long-term, not curable, and progressive to the point of a lot of suffering before death will qualify to be under palliative care.
Alright, Dr. Pang, so why insist on discussing death with the patient and so family?
It's not matter of insist, I suppose. Because it's a negative topic, most doctors would avoid discussing with their patients. In fact, a lot of patients don't want to know. I realized that when I was taking care of patients, they ask, we talk about treatment, then we talk about success, we talk about failure, and then we kind of stop there, because it's like, when failure, then what? Because in Malaysia, a lot of patients, when failure with the conventional treatment, they will then go for alternative treatment. That is all the traditional medicine, all the supplements, all the natural form of treatment, and all kinds of treatment available that people hear about. So they don't, like I said just now, if we don't accept the disease is not curable, and there comes a point where we stop trying to keep on looking for treatment that works, then till the last point, what is very sad I see is that there are many patients who till the day they die are doing chemotherapy, they are doing radiation, they are doing all this treatment, even then they never got referred to palliative care, they never got referred to hospice. Because what is happening in Malaysia is we have a big gap. We have patients who are diagnosed with cancer, they are then treated in the hospital with chemotherapy and all that. Then they are told that they are well. Then they leave lah, right? So they leave the healthcare system and they are left on their own until they relapse, right? Then they go back to the hospital, then they, after maybe a few more times, by right, if it's already not workable, they should be referred to palliative or hospice. But because there is so much negativity with hospice, with palliative in terms of death and all that, people keep on asking doctor for, oh, another chemo, another chemo. People have been 3-4 chemos, you know. And then they keep on going like that until the day they die. They are not prepared for death. Till the day they die, they never really prepare their mind and even physically, like the will and all that, you know. In fact, overseas in Malaysia is not, the law does not allow it, but in overseas they have what we call, in part of palliative care, the living will. The living will is that if I am going through a disease that I know is incurable and one day I may collapse, I have already written in a will that I do not want resuscitation. I do not want to be put on a machine. You know, that means before it happens, I already write that specifically. That is what I want. Because when I'm unconscious, then somebody will put me on the machine. Then somebody, you know, will give me life, what do you call it? Prolonging life for the sake of prolonging life procedures. But unfortunately in Malaysia, the law does not recognize living will. So what happens is that what will happen if you collapse? They will ask your family, right?
Correct.
Which family member will decide, oh, don't do? Right? They get scared, right? They will say, do. But actually, if you look at it, if the patient is unconscious, is having a drip, having a tube on the machine, isn't this just prolonging death? He's not conscious. In fact, in government hospitals, if they need the respirator for somebody, then they'll need 2 doctors to certify that this person is brain dead. Then they'll do the test and say it's brain dead ready. But in private hospitals, because you are paying, if you can pay, they may just ask you to continue. This is what I find is very sad, that there is a big gap. Therapeutic care, terminal care. In between, that palliative care component is missing. And all because palliative care has been associated with terminal care. It's not. But like I said, because the topic of death is involved and it is such a taboo and so cultural problem, we do not open the topic or force open the topic unless we have the support system for them.
Dr. Pang, what is actually the impact on palliative care with terminal diagnosis, like the physical, emotion, psychosocial, and also spiritual wise?
Well, for many patients, if you tell them point blank, you don't have much time left, they may just have 2 options. One, they may just say, why not give me more options? Another will just accept such thing, and they call what they call self-fulfilled prophecy. If you tell them 3 months left, 3 months also they will something will happen to them, you know. I remember one such patient where she was a cancer patient that has been having nasopharyngeal carcinoma more than 10 years ago, went through the radiation, was well. Every year she will go for checkup at the hospital, and they would be she'll be told, maybe she did a scope or whatever, told there's no recurrence there, and she was fine. 10 years passed by. One day her daughter decided to bring her to see me for a checkup, not just cancer but full checkup. So we did a cancer marker test for the nasal cancer, and it looked very high. So then I sent her for further assessment, and it became that the cancer has come back. And when she heard that, it was like terminal for her, even though I told her very specifically, you know, if we do the treatment again, you know, it's quite good, the prognosis, because she lived 10 years before this. First treatment cycle, she passed away. Just the first cycle. It was so shocking. It was shocking to me, it was shocking to the oncologist, it was shocking to everybody involved in the care. Because she should not die, actually. But maybe it was in her mind. When the diagnosis that the cancer has come back, she thought in her mind, no, despite of all our assurances, that it was terminal. And that itself had a very negative impact on her. And she died within the first cycle of treatment. And either that, or she gave up, or said that I don't want to go through this again. You know, I've lived enough. Which then brings to the next point, you see. A lot of times the terminal diagnosis impact on the patient is dependent on two things: the age of the patient and whether the patient has anything more to live for. If a patient is already 60, 70 years old and they feel that their life has already, reached whatever he needs to see. I remember one patient like that also. He has liver cancer. Within 2 weeks he died. Why? Because he for 1 year before that he kept saying, all my friends have passed away. I'm the only one left. What's the point of living? He kept saying that. So when the diagnosis of terminal disease came, he just took it as a, okay, this is the switch, switch off now. So the diagnosis of terminal disease on the patient and the impact, psychosocial, emotion and all that, actually we very hard to assess. Because patients do not tell us a lot of things. And we do not know their past a lot. We only know their medical past. We don't know all their other past, that maybe when they went through the chemo or whatever, they told themselves they will never go through it again. If it come back, I would just rather die. Maybe they already told themselves that 10 years ago. And so when they are told that it has come back, they have decided to switch off. I don't know, we don't think that there is a switch on and switch off for life and death. But somehow I do see that when patients switch off their desire to live, then there is no more fight. And then it's kind of the disease just takes over full force. Even though it's not so powerful, but because the will to live is not there. So the impact of a terminal disease diagnosis can affect the will to live. And that will to live is the will to live of the patient. As providers of healthcare, providers of palliative care, we can only support, but we cannot give them the will to live. Because it is their will to live, it's not ours. So we shouldn't feel very bad if for some reason we have done everything we could in explaining the terminal diagnosis and then they just shut down and decide to die. That is not our responsibility to ensure that they have the will to live. That is not palliative care, okay? Palliative care is supporting them, neither hastening death nor prolonging death. Now, which brings to, whenever we talk about the topic of death, we bring to the two extremes, hastening death and prolonging death. Hastening death is like euthanasia, which is totally illegal, even in Malaysia or in almost all countries of the world. Which is when you talk about death, people will start asking, well, so much suffering, anyway I'm dying soon, why don't you give me something and I'll die faster? Oh, that is not part of palliative care. Okay. That is illegal. Alright? We're talking about death, we're preparing for death, we're not hastening death. Alright? But prolonging death is like I said just now. The patient is already unconscious. Putting them on a machine, putting them on drip, putting feed tubes just to keep like a vegetable alive. That is prolonging death. So palliative care is neither this nor that. It is actually supporting a patient who is still thinking so that they can have the support and the family. We have to remember, the family is part and parcel of the care. So many times when patients go to hospital for treatment, they are seeing the doctor, the patient and the doctor. They forget that there's the family, the impact on the family. It's not just the patient, no. It's very obvious if you have a child who has cancer. Then it is very obvious because you have the parents who have to stop work or even take leave and all that to take care of the child. But what about an older person? It's the same one. Older people who need to go to hospitals need someone to drive them. Need someone to go in with them. Maybe they can't speak English properly with the doctor. So the impact is on the carer. We tend to forget. And palliative care, the beauty of palliative care is it brings in the carer with the picture, into the picture. What do you want in the life that is, in terms of what? What kind of care are you looking at?
So when should they get palliative care?
Obviously, right, with all the description I gave just now, palliative care when to get is a personal or a customized program. You cannot say palliative care is when they are doing the chemo. Palliative care is when they are terminal. You know, somewhere along the line, the patient needs to be prepared for palliative care. In fact, Malaysia has already started palliative care in the hospitals, in government hospitals since the 90s, and they have palliative care unit. So whenever the hospital doctor in the therapeutic side, that is the chemo, the radiations, finds that patient is not responding, then they will refer to the palliative care side. Okay, in a government hospital setting, it is very easy because patient already not paying, government paying, right? So when the government decides, oh, this treatment is not working, move to hospice palliative care unit lah. Patients just sees it as part of a care. It doesn't see it as, oh, going to terminal care, you know. But in a private setting, it's kind of difficult, right? Because in case, if for example, you go to see an oncologist and she started you on some chemo and all that, and after 3 months they rescan and it's not responding, they would want another chemo, right? Because they are paying, they think they can pay, or the insurance is paying. They will ask for another chemo. They will keep asking for more and more chemos. When is the time to refer? Then it all depends on the oncologist. He should be putting his foot down. Hey, 2-3 cycles, 2-3 types of chemo already. No more chemo already. It's time for palliative care. But again, with the negative perception of palliative care, people will want, what will they do? Because they are private paying patients, they will go and see another oncologist. Oh, so and so say I can, oh no, or they go Singapore. Alright, and the usual treatment in Singapore, I notice when I have few patients go in Singapore, oh, they say cannot do, we can do.
Oh.
They can do when other people cannot do. They have medicine when other people have no other medicine. You know, why they're just doing again another form. So this is where I said that when the patient does not accept that the disease is incurable, they will keep going everywhere. They will keep hearing. They want to hear. They can't do, I can do. They want to look for that kind of care, you know, which in the private setting, that's why you see in private hospitals, except for Mount Miriam Hospital, which is a cancer hospital that has a palliative care unit, private hospitals in Malaysia do not have palliative care unit. They only have therapeutic care unit for cancer. It is only in government hospital that have, because budget is limited. Once this patient not responding, use the budget for someone who's responding, move the patient to palliative care. That is the proper care lah. Unfortunately, when the patient has private care or have insurance, they go on like this. Unless it's like in US, insurance will pay, but when the doctor certify, hospice have to go already. So the line of when to take palliative care is a very blur line, but a line that I think in a way patients' relatives have to initiate. This is where education of patient relatives is very important, because as the patient is so emotionally involved in the living and the dying, because it's my life, right? If you tell me that actually there's nothing left, then that switch, the will to live will get switched off, and then all that, you know. But actually getting palliative care early is good, because you talk, patient is still of sound mind and very alert, and you just talk about, you know, someday, you know, after the, if sometimes the chemo don't work, there is still other treatments for your pain, for your difficulty, or your swelling of feet and all that. If it's introduced like that early in the treatment plan, that means by the oncologist or the first attending doctor, then later on when this topic come up, there is not so much negativity. Because if it's never introduced, the thought of moving from therapeutic to palliative is part of care, then when it's thought up, the next question is, am I dying? That's why you asked me to go there. You know, so really it should be early. That means that the education of the relatives, the education of the community, the education of the doctors, the nurses, in the early part of the care, need to palliative, the topic of palliative care need to come in. Not, oh, I'm sorry, there's no more chemo left, there's no more radiation that can work. you need to go to hospice already. At that point, everything is wrong with that, the way it's introduced.
Okay, so Dr. Pang, in Malaysia, where should they get palliative care?
Okay, in Malaysia, the palliative care units are in the government hospital. These are the hospital-based palliative unit. In other words, but they're only dealing with hospital patients. In other words, if you are from private hospital, you cannot go to the palliative unit hospital. So from private hospital, the only other palliative care that they can refer to is the hospice Malaysia, or in every state of Malaysia there are NGOs, non-government organization, composed of volunteers who will take care of palliative care. Most of these are house-based. In other words, the nurse or the doctor will visit the patient in the house and they will give the care there. And by the time in Malaysia nowadays, when palliative care is involved or hospice is involved, it's always on the pain management side, because the cancer has grown to the point where the patient is having a lot of pain. And so when the pain is management, one of the key drug use is opioids or morphine. And because morphine is addictive, but you know, between the person who has only 6-9 months left to live, getting addicted to morphine and controlling the pain is between the devil and the deep blue sea lah. So the question of where to get is, the people who are providing the palliative care must have a connection with hospitals that can provide morphine, because morphine is a control item. So you cannot just walk into a clinic and buy morphine. Most of the time, morphine is only sold through the hospital through a prescription, because it's addictive. Morphine is actually a cousin to heroin. You know, heroin is a drug that is addictive, so morphine cannot be just bought like that. So all NGOs who are involved in pain management in hospice, they have connections with hospitals. That means the nurse visits the hospital, then the patient in the home then knows that the patient needs a morphine. The nurse will write a prescription. That will go to a hospital to collect the morphine or buy the morphine, and then they start the drip. Nowadays they even have drip that the patient can control. In other words, if I'm in more pain, I press more morphine. If I less pain, I press less morphine. So the patient can control. But of course, morphine has its side effects, and there are patients who actually don't want to use. This is again boiled down to that addictive nature of morphine. So some people say, I die also, I don't want to use this kind of things, you know. But then the pain is not just the patient's, no. Do you realize that when you talk about pain management for the cancer patient at home, the pain management is also for the carer? You may not be in pain, but if you see your mother or your child in pain, you are very pained. You don't need the morphine, you need some psychological help for that grieving process. So palliative care at home, also when the nurse visits at home, also attends to the grieving parent or the grieving child of the relative. So home-based palliative care therefore is very successful, because you get to see the whole family. You are not dealing just with the chemical pain of the patient. There is a social support and all that, and people are anyway quite sick to ask them to go from one place to another place. Oh, another appointment, one appointment to oncologist, next appointment palliative care. You know, it's just too many appointments at that. So it's home-based is very good. Community-based is also there, where like in Hospice Malaysia, they have a daycare center for palliative. So it's not for terminal, but it's for palliative. So as long as you are a cancer patient who's already diagnosed, then maybe exercise, physiotherapy and all that, those people who can still go, they can go to a center where they have classes and things like that. And of course, lastly, the hospital-based ones, which in Malaysia is only in the government hospitals, in the palliative care unit, and only for government hospital patients.
Thank you.
So in conclusion, palliative care in Malaysia is still in its early stage. There's a lot of room for growth, and we need more exposure to the public on palliative care, so that people don't come to encounter palliative care only when they are sick, but when they are well, they know there's such a thing as the gap between therapeutic, palliative and terminal care.